Hello, everybody. We'll be starting the webinar soon. So I'd like to welcome you. I'm Winnie from Group Education, and I'd like to welcome you to the fourth installment in our seminar series, Humanity at the Heart of Healthcare. And that's a series that's brought to you by my team, Education Research in Group Education in NHG. So this seminar series aims to highlight issues that are at the intersections of social science research, humanities, and clinical practice. First off, as we're waiting for more attendees to stream in, some housekeeping matters. So we do have CME Nursing Board SPC points registration for this webinar, and these will be collected together with your feedback form at the end of today's webinar. So do wait around and give us your feedback as well as your names for your CME points. Okay, so we will flash a QR code for that at the end of the webinar. We are also at the same time planning for more webinars in the coming year. So if you're interested to hear more from us, then do stay around. We will register interested names and we'll keep you updated on our mailing list. So during the webinar, do post your comments and your questions to our speaker and discussants using the Q&A button that's at the bottom of your screen. So we will do our best to address these questions and comments during the Q&A segment that's at the end of the webinar. All right. Okay, so today I'm excited to present to you Dr. Michelle Chiang, our speaker. So Michelle is an assistant professor of English in the School of Humanities and Social Sciences in NTU, Nanyang Technological University. She also serves as the coordinator of the Medical Humanities Research Cluster in NTU. Now, Michelle is a literary scholar, and how we got to know her was because her literary interest intersects with medical humanities with a focus on loss. She is currently the principal investigator or PI of an MOE academic research Tier 1 grant that focuses on the value of patient stories and narrative ethics, including at how we currently feature them in our medical curricula, institutional website, and how these patient narratives can offer healthcare professionals insights into the lived experience of being a patient. And I think if you're interested, do ask Michelle more about this project in our Q&A. Now, for today, our clinician discussants are Dr. Joanne Hua and Dr. Joyce Yap. So Joanne is a senior consultant in the Department of Geriatric Medicine in Tan Tock Seng. And to us in the education office, she's a very familiar face because she's our PD or program director for our NHG Geriatric Medicine Residency Program. In the Institute for Geriatrics and Active Aging in Tan Tock Seng, Joanne also serves as the education and learning lead. So welcome, Joanne. Joyce is also familiar to us. She's a consultant in the Department of Continuing and Community Care, also in Tan Tock Seng. And she is the clinical lead in the community health team in her department. So when I spoke to Joyce in the pantry in our office, she's currently pursuing her master's in health professions education. So good luck with your MHPE, Joyce. Yeah. And in doing that education work, she's interested in looking at gaps in health and in healthcare delivery in the community, and to see how conversations, collaboration, and research can help address those gaps. So overall, I think in Joanne and Joyce, we have two excellent and very thoughtful clinician educators who are more than qualified to share about what patient stories mean to them as clinicians and as educators. So thank you, Joanne and Joyce. Thank you to Michelle for spending your afternoon and your lunch break with us. So now I'll hand over the time to Joanne and Joyce to start the ball rolling. Over to you.
Thank you, Winnie. Yeah, thanks for having us. Yeah, so I thought before we begin, maybe I just want to ask Joyce a question. Hey, Joyce, do you know what are illness narratives?
Yeah, thanks, Joanne, for the question. Illness narratives was something that was really not familiar to me until maybe a few years ago. But this really reminds me of an incident that I want to share with everyone. So many years ago, when I was a junior doctor, a very senior consultant asked me during ward rounds when we saw a new patient, Joyce, what is the patient's story? So I looked at him bewildered. I didn't know what he was trying to say. Then after that, he rephrased his question. He said, what is the patient's presenting complaint? And it was only then that I started presenting the case as per my usual. But this incident really stuck in my mind for a long time. And it was only many years later that I realized that what the senior consultant asked me was very wise, because how do we really hear the patients, listen to the patients, and know who they are beyond that acute hospitalization or beyond that episodic clinical encounter we have? And it's only through listening to their stories in more depth that we can really manage them well, I feel. So to me, illness narrative is a story that the patient tells to give coherence to the distinctive events in his or her life. How about you, Joanne? Do you have any experience with illness narratives or patient stories?
Yeah, well said, Joyce. I also, was reading out, before this session, and I thought that if I had known more about illness narratives as well as the value of listening, it could have made a lot of difference in the relationship I have with my patients, as I journeyed with them through their conditions. I remember clearly this patient that I had, that I was journeying with her through this process of dying. And every time she comes to me, she will tell me she's very scared of dying. Me being the good geriatrician, I try to look for help in evidence. I try to look for literature that supports that tells me how I can support her in this spirituality domain as she approached her end days. Yeah, but if I had known about this earlier, I thought what I would have done differently is I would have gone back and asked her about her stories of the patient, of the relatives perhaps that she had encountered dying, and what impact did it have on her that it made her so fearful of dying. I read this phrase in one of the articles. It says that as doctors, do we hear the words or do we listen to the stories behind the words? And I think that it is important, through this session that we come to realize that it is not just the words of the patients that are important, but it is the stories that they bring with them that tells us more about their experiences that we can help, understand and journey with them henceforth. Yeah.
Thanks, Joanne. I think that was really a very powerful story. I also vividly remember this patient because we did co-manage her. So without further ado, right now, Michelle will share with us about illness narratives and also the power of stories within words and beyond words. Michelle, please.
Thanks, Joyce and Joanne. Hi, everybody. I'm Michelle. Good afternoon. All right. So thanks for sharing those stories. Today, I'm going to try to expand everybody's minds a little bit to think about patient stories as not just the patient sitting right across from you, but patients in a text, whether it's a non-fiction or even a fictional work. All right. So I will share my screen with you now. Let me know if it's moving for you. Is it moving for you? Yeah. Okay. Cool. All right. I must begin with the title. I know that for publicity that possesses the value of patient stories. But that's just one part of a larger project on care to imagine, imagine to care. So really putting the concept of care together with the imagination. Yeah. So today, I'm going to introduce to you a very key concept in my entire work, which is the concept of the other. Yeah. So here, the other. So today's question really is, why read narratives of care and illness? Like, why do we read that? Why should we read them? What is their value? Yeah. So when I say value of patient stories, like I said earlier before I started, I want to expand your understanding of patients to include everyone who bear the sickness. So etymologically, the word patient means to bear. All right, so the etymology of the term is broad and certainly not restricted to the sick patient bearing illness passively. So in the context of my work and today's presentation, when I say patient, I'm really referring to all who bear the effects and consequences of an illness, including the afflicted and their caregivers. So not just their family caregivers, but also the healthcare professional. Yeah, I'll be using interchangeably the term narratives of illness and care with patient stories as well. Yeah. You can ask me this later during Q&A. What's the difference between stories and narratives? And I have a very good answer for you. So remember to ask, okay? All right, so let's begin. The other. Now, the concept of the other is it's quite negative, right? Unfamiliarity and discomfort haunt our collective impressions of otherness. The concept of the other is rife in philosophy, and I know this part will put a lot of people to sleep, but it's still very important to know like where this concept comes from, where it's heading, right? So existential phenomenologist Martin Heidegger asserted that the otherness of others shapes our understanding of ourselves as being. So we come to understand ourselves as a certain kind of person based on the differences of the other. Yeah. Post-colonialist Edward Said discussed the Western construction of the Orient as other, and feminist philosopher Simone de Beauvoir explored patriarchal marginalization of women to be always already other to men. The thinker of interest in this talk today is Emmanuel Levinas, whose concept of the other emphasizes our responsibility for the other when we encounter the face of the other. Born to Jewish parents in 1906 Lithuania, the French philosopher's concept of the other was influenced by the violent political events he bore witness to in his lifetime. His principal focus on the other stems from his critique of instrumental reasoning in Western philosophy, which aims to reduce the other to sameness and identity in a bid to achieve absolute certainty with theoretical reasoning. So anything that we don't understand, we try to understand it to death and reduce it to something familiar in order to be able to cope with it, in other words. Yeah. So I will not go into too much detail about Levinas's concept of the other in this short presentation, but I must highlight the following key points in order to go on, right? Hence this quote over here. Levinas's responsibility for the other can be read as a response to the other's differences at the point when a potential caregiver heeds a call for care. So this is the connection that I'm drawing between the concept of the other and the caregiver heeding a call for care. Levinas tells us it is impossible to fix limits or measure the extreme urgency of this responsibility. Responsibility for the neighbor is precisely what goes beyond the legal and obliges beyond contracts. So it goes beyond a contractual relationship. It comes to me from what is prior to my freedom, from a non-present and immemorial. A difference gapes open between me and the other that no unity of transcendental apperception can undo. My responsibility for the other is precisely the non-indifference of this difference, the heeding of this difference, the proximity of the other. An extraordinary relation, it does not re-establish the order of representation in which every past returns. The proximity of a neighbor remains diachronic break, a resistance of time to the synthesis of simultaneity. I will unpack this gradually, but for now, what's important for us to understand is the highlighted word here, difference. So that's the key word here. Our responsibility for the other, in other words, is founded upon difference and not similarity. It's precisely because the other is different from me. It is this difference that calls to us for help. This is an important idea to hold close to our hearts and minds as we employ Levinas's responsibility for the other to conceptualize, imagining, care for, and relating to the other. Taking responsibility is heeding the call of difference or differences between the carer and the care recipient. The call for help is the call of the other's differences. Therefore, care relations are predicated upon our capacity and willingness to imagine caring for someone who is other to me. My responsibility of care is towards one whose differences I can never grasp fully, whether it is a separate being to me or my other self. Now, I added this my other self because it's widely understood in our disciplines, in these humanities and social science disciplines, that there is a part of the self that is other to myself. right? Sometimes we can't say with confidence that we know ourselves thoroughly, yeah? So hence my other self, yeah? So answering the call for care as call of the other is a non-indifferent response to the difference or differences between the one who is caring and the one who is receiving care. But what exactly are these differences? These differences may seem readily apparent or may be anticipated by professional experience, but they can never be fully grasped. A failure to recognize ungraspability of the other could still result in technically effective care. So in other words, an act of care could still be performed. To achieve care that is not merely performed and dependent on the care recipient's conformance to the carer's sphere of rote knowledge and experiences, the care provider or giver must consciously imagine the one being cared for as having the potential to, if not flourish, then at least adapt well to their changed and changing circumstances. Those who are very good at caring, very good at their job, at their profession, do not need to be told of this. They are always constantly consciously imagining the one being cared for as having the potential to flourish, or at least to adapt well to their changing circumstances. So in other words, the carer must imagine care in the other's place to relate to the other. The main route to understanding the other and their needs is via the leap of the embodied imagination. Now, I'm not talking about empathy here. I'm talking about the imagination, an embodied imagination, without which caring relations between humans cannot be established. Right. So, narratives of illness, and we're only halfway through the slides, and I'm already giving you the answer to the research question of today's presentation already. The value of these stories, narratives of illness and care, they provoke and facilitate such leaps of the human imagination. As writers, audiences and readers enter the fictive worlds of stories, they enter an other world to become more human. What does it mean to become more human? This has nothing to do with the principles of humanism or even medical humanism. Alan Sitsu asks and answers, we live, but why do we live? I think to become more human, more capable of reading the world, more capable of playing it in all ways. This does not mean nicer or more humanistic. I would say more faithful to what we are made from and to what we can create. I cannot emphasize this enough. This has nothing to do with niceness. Yeah. So to be more human is to engage with our imaginative capacity to create. And I would add co-create with other humans, the multitude of ways in which human experiences are lived. Right. So the word playing then, right? Oh, sorry, I missed this slide. So more human. So the word playing, therefore, does not only refer to the roles we actually play in our lives, but it is also indicative of our capacity to imagine embodying realities by interpreting or playing them in our minds. Right. So when playing stories in our minds, we are practicing an engagement with the other or others through the hermeneutic circle or the circle of understanding. Now I'm going to explain this, describe this diagram a bit. This diagram is freely available under Creative Commons license. You can find it anywhere. It looks complicated, but it really isn't. Okay, so right here you see two big circles, context and text. So context really is, imagine this as your brain, right? You're assembling things that you're reading from the text, right? So imagine this, okay? Let's imagine this with me. You are at a library right now. You're in the library or you're at a bookstore. You pick up a book maybe because the title attracted you somehow, right? It's something that you would like to read. So what you do is that you pick up the book, you turn to the back of the book and you read the synopsis. You're thinking, yeah, this is something that I think I would like to read. Yeah. So by this time, like before you even walk towards the cashier, you already have an idea of what this book is about, right? This forms the initial understanding of the book's context, right? So you have an initial context in your mind as you carry the book home. As you plop yourself down on your couch, and you start reading. This is when, looking at the diagram, I don't know if you can see my cursor, but you move towards stage number 1, which is from context, this initial context. You move on to the text where you start reading, and your context expands more, right? You get more information from the text, and you develop a new understanding. So this is stage 2, a new understanding, and your context broadens, deepens, or is even perhaps overturned, right? The initial understanding is even overturned. All right, so this new context, right, whether it's expanded, broadened, deepened, or turned completely on its head, what this does is that this new context, right, you will carry it with you as you approach the text at the second seating. You're going to continue reading the text again, and you're getting more information, accumulating new understanding, and your context expands a bit more. Yeah, so this is the hermeneutic circle. The word hermeneutic sounds very intimidating, maybe like, oh, it sounds very cheap, right? But it really isn't. If you think, just think of it as an interpretive circle, right? So it's about interpretation. Hermeneutics is about interpretation. So this is the interpretive circle that most people would engage with as they are reading, all right? Now that I've explained the hermeneutic circle of understanding, let's move on to what Gadamer has to say about this circle of understanding, all right? So bear this diagram and what I've just described to you in mind as you listen to what I have to say, what Gadamer has to say about this. Far from it being the case that whoever listens to someone else or approaches a literary text must bring along no pre-opinion about the content and must forget all his own opinions. It is rather the case that openness for the opinion of the other or of the text. So if we go back to the slide here, this diagram, you can think of the text as the other, right? The text is other, okay? It is rather the case that openness for the opinion of the other or of the text will always include setting it in relation to the whole of one's own opinions or setting oneself to it, but always bring our pre-opinions into reading the text. Put differently, opinions are indeed a changeable variety of possibilities. But within this variety of what people can think, i.e. of what a reader can find sensible and thus can expect, not everything is possible, and whoever hears past what the other is really saying will not in the end be able to fit it into his own manifold expectation of meaning. So here too, there is a standard. The person who wants to understand a text, and this is an important point to take home with you, the person who wants to understand a text is ready to be told something by it. So a hermeneutically trained mind must from the start be open to the otherness of the text. One has to be aware of one's own bias so that the text presents itself in its truth in the matter at hand against the interpreter's pre-opinion. So what does this mean? Let me unpack this for you. So when we ask the question, how can I help? Right? We're really answering the call for care. So to answer the call for care is to want to understand how one can help with the needs of the other. Put in the context of Gadamer's description of the circle of understanding quoted above, wanting to understand is being open to the fact that pre-opinions, so your initial context, initial understanding about a situation or the subject of care could be toppled, changed, broadened, deepened at any point of this hermeneutic enterprise, in this interpretive enterprise. This is akin to what Levinas refers to in the previous quote on the non-indifference of the other's difference as an extraordinary relation. Extraordinary because it does not re-establish the order of representation in which every past returns. So every time we shift from text to context, and then again, new context to text, every time there is this shift, there is a re-establishment of the order of representation. It's not a repetition of, it doesn't mirror, it doesn't repeat our expectations. Something new is added, something different, yeah? So to elaborate, as an understanding of the other is being constructed, the pre-opinions of the one seeking understanding are called into question. They change. A stubborn attempt to hang on to these pre-opinions and prejudices on a subject matter, instead of letting the other's differences permeate and calibrate an understanding of the other, would hear past what the other is really saying, highlighted here, and lead to a failure to understand. An openness to the otherness of the text is therefore to be comfortable with the uncertainty of this process that vacillates between familiarity and strangeness of what is said, which Gadamer refers to as the between and the true place of hermeneutics. Russia I'll say at all elaborate that Gadamer viewed hermeneutics not as developing a way of understanding, but as a means to illuminate the conditions in which understanding, perception, experience, and knowing itself takes place. So really an amalgamation of our existing understanding, lived experiences, and the creative imagination. Writers and readers co-create relationalities that are not transcendental, but immanent within itself. This is actually very different from what we would normally understand of relationality as some kind of commonality that transcends the self and reaches out to the other. So this is my assertion, that writers and readers co-create relationalities that are not transcendental but immanent within each self. By transcendental, I mean go beyond the limits of the self to reach another. Writers and readers do not rise beyond the limits of the self to reach another. Let me repeat, the relationality between writer and reader is immanent within each self. It does not go beyond the limits of the self. My preliminary observation is this, that relationality is fundamentally established in processes of writing and reading a text at different points in time. For instance, relationality in the writing of an illness narrative is established with an imaginary reader prior to the publication of a text, right? So this, as the writer is writing, the writer is imagining a reader. So this reader has not come into being yet. Relationality with the text as other in the reading of an illness narrative is established at the point of reading it. This problematizes the expectation that relationality must always be a neatly graded and self-transcending connection between people. The value of patient's story thus lies in the pocket of space or gap that affords the writer and reader a relational understanding that is immanent to each self. This space is in fact a door to interpretive possibilities rather than a frame that confines illness stories to a static function of invoking or cultivating empathy. Ultimately, if there's only one thing that you take away from today's session, I hope it is this, that narrative worlds are open to the reader's entanglement of lived experiences and imaginative possibilities. Such an entanglement offers the potential to create models of social relations that one can potentially build upon or not. I've included this concept of the immanent imagination here because I do want to point out something to you. I know that I've been talking quite a bit about the imagination and creativity. And it's important to point out that before Rene Descartes came along, the imagination was thought of as a bridge between phenomenon and reason. So it's like a passageway or a means for us to process what we see, what we hear from external reality, process it, and then incorporate that into our reason, right? So before Descartes, this was that. But Rene Descartes came along, and what happens was that imagination became bound up with this binary opposition with reality. So imagination became your unicorns, your Narnia, your Harry Potter, everything that is not real, right? So what I'm really talking about is that narratives of illness and care supports our employment of the immanent imagination. The immanent imagination can be defined as an imagination that is in no sense static and free-floating, but entirely caught up in projects of action that aim to have real effects on the material world, and as such, always changing and adapting. David Graeber uses crafting a knife or a piece of jewelry or trying to make sure one doesn't hurt a friend's feelings as examples of the immanent imagination that has real world consequences and effects. But I would like to add that reading texts, narratives of illness and care have that real world effect of honing your ability to attend to the nuances of lived experiences. And once you have trained yourself enough, when you can think of reading texts as a kind of training for your keenness, your competencies. Once you've trained yourself well enough, when you're listening to patients, when you're talking to patients, when you're having a conversation with anyone, really, you'll be much better at attending to the nuances, to what they are saying and what they are not saying, even as they are speaking. Yeah. So that's all I have for you. I was also it was also suggested that I give you a list of recommended readings. And here are some Singapore titles and international ones. I specifically foreground the local ones because I think that they don't gain as much attention as they deserve. So there's Mahita Vasu's A Good Day to Die Inside a Suicidal Mind, The Sound of SCH by Danielle Lim, Cry in the Dark by Terence Ang. It's quite a recent title. And Li Shan Chan's A Philosopher's Manners, who incidentally is here today at NTU for a research session. Yeah. So and then there's the international ones that perhaps many of you are already familiar with. There's Paul Kalanites When Breath Becomes Air. And I highly recommend The Museum of Words, a memoir of language, writing and mortality by Joanne, who was an Australian writer. Yeah. So with that, thank you very much. Please feel free to scan the QR code if you want to learn more about medical humanities research. Get in touch with me. Thank you.
Thank you so much, Michelle. I think this is actually the second time I'm listening to this, and I must say, each time I listen to it, the more I take away from it. So maybe I should listen to you talk about it the third time.
Thanks for being willing to
Okay, we have some questions in the Q&A. Joanne, I'll just read the first question first, and maybe you can take the second one. So the first question is from Prof. Aaron Ang from Department of Psychiatry. I'm just going to read his question because it is very cheap to you. So Prof. Aaron asks, is there an Eastern philosophical concept of the other in Taoism, Confucius, or Brahman traditions?
I have to be super honest with you. Like, these are all very fascinating areas of inquiries, but I'm afraid I'm not familiar with them to be able to answer this question. I'm sure there is. Yeah, but I can't be sure. I'm not sure. I'm sorry. My area is really I look at a lot of continental philosophers. Mainly because I started out as a Beckett scholar, Samuel Beckett. He's a European playwright. So my studies have been quite focused on European philosophers. Yeah. Apologies.
Okay, thanks for that, Michelle. I think Prof. Ang has another chim question. Maybe this one is easier to answer. He's asking, what is the role of the senior clinician in helping his or her learner appreciate the thicker concept of his story or her story, i.e. the patient's story, history?
Why specifically the senior clinicians in this question? That's my question. Yeah, because I wonder what is the why senior clinician?
I wonder whether it is in his role as a senior clinician himself, and how does he bring value to the interactions that he has with his residents, that he can help them, apply whatever he has heard from you today, I think.
Okay. So what is the role of the senior clinician in helping his or her learner, as in a junior clinician, for example? I see. From my interactions with many clinicians, especially the ones who feel very strongly about the importance of patient stories, they've told me that this is almost an uphill battle, right? Junior clinicians they still don't really understand the importance of these stories. They only know that they have to get whatever they need to get done, right? So what is the role of senior clinician? I think it's the emphasis on understanding these concepts that maybe this is quite self-serving. Understanding these concepts that I'm trying to articulate, the concept of the other and how that has a specific implication on your self-knowledge as well. So the personal stakes have to be emphasized. That you're not listening to the patients because you are trying to. We can't really use the patient-centered care because it's very even though it's called like patient-centered or person-centered care, very personal, but it's actually quite depersonalizing for the, I don't know, for the healthcare worker, perhaps because the patient is put at the centers and then where do I stand, right? So I think concepts like the other puts into focus that the relationality between self and other, with the other is inextricably tied to the self. So if you can try to angle it in such a way to the junior learners, let them understand that it's also for their personal development, for understanding themselves. I think that would be really useful. This reminds me of the conversation I had with Joyce the last time we met. Joyce, you said something about a patient who was talking a lot about things that don't really matter. Do you want to like describe that?
Yeah.
Yeah.
Sure. Actually, it was like a hypothetical patient, but I think all clinicians here know what I mean. I think many healthcare professionals in our head have this illness script because that's how we learn in medical school or nursing school. Like, a patient with a pneumonia should present like this. I should find this, and therefore I do this. So it's a very like neat mental framework we have, but oftentimes real life is not like that. Especially for me and Joanne, we are both geriatricians, so older adults, and in fact, I think many people don't have these scripts in their head like what healthcare professionals have. So when they tell you their story or they're presenting complaint, it doesn't come out very nicely in that way. So for example, the ama may tell me, you're asking about her shortness of breath, and then she'll tell you that, oh yeah, 10 years ago my grandson also had shortness of breath, and then it was this. And then, oh, my son also went to see a GP for shortness of breath, and then the GP told him it was this. And then in many people's head, including my head, even right up to now, there's a lot of cognitive dissonance. You feel slightly frustrated. You're like, this doesn't fit in the mental framework in my mind. There's a lot of tension there, and you feel like you're not telling me the story I want to hear. And I wonder, like, what you're talking about, how does this relate to this tension that a lot of healthcare professionals have when it comes to illness scripts and what lived experience of real patients have?
Yeah. So thanks for sharing that. So this is the part where I was talking about in this presentation related to the question that was just asked as well. The part where I talked about how stories are really pockets of space or gaps for us to interrogate our relationship with the person who is telling us a story. So just now you described how frustrated you were, how frustrated anyone would be, like when you are trying to find a story that will fit a template that you have, but it just doesn't fit. So the particular pocket of space, what I'm referring to, is really this space for us to think about our reactions to the story that doesn't fit. I talked about how relationality is immanent to the self. It really speaks to this idea of reflection. I know that clinicians are very familiar with reflective writing, but I'm saying that this very specific moment where there is this cognitive dissonance, right, this gap, right, this is an opportunity for us to think about, why am I reacting this way? And like, why is this person telling me this completely unrelated, this story that's completely unrelated to the present condition? Like, why is this auntie going on and on about this thing that's completely unrelated? Does this indicate that that this auntie has a perspective of me as a clinician that I am unaware of? Like, is she trying to get me to hear something? Does she think maybe there's something hereditary in the condition that she's experiencing? Is she concerned about that? So instead of being like very frustrated, this doesn't fit, like think of it as an opportunity to get to know yourself as a professional, as an individual. And what this auntie is really trying to say, how to dig beneath the surface of the text. So this is what I was talking about earlier. Like so dig beneath the surface of the text. Maybe not what I was talking about earlier, but what I've been writing, because I'm writing a book right now. So all these things are coming to the fore. So think about that. And it really doesn't take a lot of time, right? It doesn't take a lot of time. At that point, where if you can stop and think of this as a opportunity, a pocket of space for you to consider like what is happening here, what is spoken and what is left unspoken, then I think this would be a very good opportunity for you to develop not only as a person but also as a professional. Yeah. Another thing that I want to point out is I don't know how to tell you how to help your learners thicken their understanding. What I can tell you is this, that there needs to be an emphasis on the value of patient stories as having value not only to the patients but also to the healthcare professional. When we talk about patient-centered care, right, we always talk about how patient-centered care would improve like patient outcomes, or improve this and that. But hardly do we hear like how that could benefit healthcare professionals. Yeah. So when we think about stories, when we think about how stories, like if we listen to them, it could help patients feel better, or it could help us understand the patient better. We must also understand that attending to patient stories also helps us understand ourselves better. So I think this is the only suggestion I think I have the expertise to provide you. Other than that, as a senior clinician, you would know much better like what your job entails. That's why I asked like, why senior clinician? Like, who am I to tell you how to do your job, right? So that's my answer.
Yeah, so I think thanks, Michelle. I thought to follow up on that question, you mentioned a lot about relationality. Yeah, but I think to many of us, it may still be a very fluffy term. So I'm just wondering, can you help put it in some layman's way of understanding what do you mean by relationality, and how is that different from compassion and empathy, which you also emphasized in your presentation?
Oh no, I didn't emphasize empathy and compassion because I think that relationality there are probably elements of empathy and compassion in there, but we cannot force people to have empathy or compassion. That's my take. I know that there are different definitions of empathy too. There's clinical empathy, and then there's like there's emotional empathy and all that kind of distinction. But the word empathy, I think, has become people keep talking about it, but there isn't a specific definition of what empathy is. What I want to talk about is relationality. Relationality is understood widely as connection between people. So in other words, it just means connection. So how do you relate to someone? Can you relate? And the concept of relationality is always undergirded by similarity. Connection is about similarity. I share something in common with you, then I can connect with you, right? What I would like to emphasize is that what I'm doing differently, what I'm saying differently, is that relationality is, I think the word cognitive dissonance, Joy, is the one that you use. Dissonance is a bigger, it is perhaps a better term than connection. Relationality needs to have some kind of gap. We need a gap in order for us to contemplate connections between people. We need to, so that's why I keep emphasizing differences. Like, so for example, as a physician speaking, as a clinician speaking with a patient, you need to be highly aware of your difference in terms of your privilege, in terms of your education background, in terms of your power over the patient, who is the vulnerable party here. It's all about differences, and this difference is that gap between myself and the other that I want to relate to. So without consciousness of differences, you're always thinking about, oh, like what are similarities, what are common grounds? Wow, she's also a mother and I'm a mother. She's also somebody's daughter and I'm a daughter. No, as in like similarities can only get us that far. We need to be more aware of our differences with those who are more vulnerable than us. And somewhere else, I also argued that the patients and every one of us, we will be patients one day, right? Patients must also be highly aware of these differences instead of trying to always pander or trying to or feeling like, you know, because you're ill, so you're the vulnerable one, so somehow you are lower in this like relational hierarchy, then you have no right to speak up, you have no right to ask, or even if, or the other way around, you feel like you're the consumer, so you have all the right to speak up and demand this and that. It's also important for the public to understand the differences between myself and the healthcare worker. And not just the physician, but I'm referring to healthcare professionals, like the entire spectrum, right? We have healthcare workers who are precarious labor workers as well, right? They're not just healthcare professionals, right? There are workers who are in very precarious labor conditions as well. So we need to educate the public. The public needs to be educated, and the healthcare professionals need to be educated as well of of the differences between myself and the other. Right. So this is my idea of relationality, and emphasis on differences instead of finding somehow common ground, similarities, so that this person is more deserving of my care, more deserving of my attention. Does that make sense? Yeah. So that's my stand.
I think following that question is a question from Dr. Tan Tock Seng, who is from GS.
Yeah.
So I think he's asking, how do you foster relationality between a surgeon and a patient who needs emergency surgery? I think it's in the context of time that they may not have, since they need to quickly push the patient into surgery. Yeah, where then there's a pressure of time to make decisions when the patient will have the vulnerability of losing control. So
Yeah.
maybe you can answer that question, Michelle.
Yeah, sure. I think I might be a bit out of my depth here, mainly because, I mean, you are the professional here. But what I really would like to, and don't take this question away because I want to read it carefully. When you say foster relationality, like why do you want to foster relationality at this very urgent point in time, when practically you should be saving this person's life? As in, is this person even conscious enough for you to establish relationality, right? So this is my question. So when we're talking about patient stories, right? I specifically for this presentation, I'm talking about honing the skill of competent listening, of identifying the nuances of what people are saying or what they are saying but actually not saying, right? Through reading, whether these are texts or like memoirs written by actual patients or fictional texts. But at this point, like in this described scenario, if the patient is not conscious, how do you establish relationality, right? But if their family members are around, friends are around, then these are your opportunities to get in and understand like what needs to be done. So for example, if there's an amputation is required, what do you do? What do you do? Like, do you like amputate immediately, or do you consult the family members on what they think the patient would need? Because at this point, the patient is not conscious and unable to answer these questions. Do you go ahead and operate, or do you ask? Conscious and need to find trust with the healthcare worker. All right, so most patients are conscious, and so you ask the patient, right? What is the preferred thing? Like lay out the pros and cons, and then really listen. Now I know that I'm guessing what you're asking now is that how do you establish relationality in a very time constrained environment? Is that right, Dr. Tan? Yeah. If so, then what I would like to say is this, and this is not in the emergency department, all right, but as a patient myself, I was down with respiratory tract infection several weeks ago, and I shared this at the SHBC convention recently, when this idea of time constraint came up again. I was feeling really, really sick, and I had to take care of a 2-year-old toddler. My husband is constantly away, not in Singapore at work. So I was alone and I had to take care of my kid. I was very, very sick, and I went to my GP asking for non-drowsy medication because I cannot afford to be drowsy because I need to care for my toddler. And I told him this, and then I said, I only had 2 hours of sleep last night. I'm really very exhausted. And then he said, he didn't do much. All he did was to look me straight in the eye and said, "Oh man." All he did was this, and this took like less than 2 seconds, and I immediately felt better. I'm speaking to you as a patient right now. I immediately felt better because I felt like I was heard. Yeah. Then incidentally, after sharing this at the conference, it was brought up again at another conference in NTU, not by myself, but by my colleague who was at the SHBC conference. And he pointed out, he brought this up again when the question of time constraint came along. And another physician took this scenario, this anecdote as a tip for how to manage her patients. So Dr. Mavis Ang, I don't know if she's in the crowd right now, she used this and she said that it was to a very good results, as in she tried using this with her patients and they were they thanked her and said that they've never felt so heard. Even though all she did was to say like, oh, like, oh, okay. Yeah, so it only took a few seconds. It only takes a few seconds for relationality to be established in this sense. Yeah, but in this sense, all right. So the differences, the one that I talked about relationality, we could read differences in this, that I had enough sleep, you didn't have enough sleep. Oh man, like I can empathize. Like if I were you, I'll feel terrible. But I'm not you. Okay, so you understand that you're in this position to say, oh man. So this is an identification of like, this is you seeing that this is an opportunity for you to insert this gesture of care towards your patient. So I don't know if this makes sense to you. Trust cannot be built in an instant. And if you're telling me that this is happening in emergency surgery, it cannot be built in an instant. But that moment of relationality, that gesture of care can be enacted by just putting yourself in the patient's shoes and thinking about what this means to the patient. Let's say it's emergency surgery, now you need to amputate, and you're asking this patient who is conscious that you need to amputate, and patient, I can't afford to lose my hand because I do manual labor, and sometimes you don't even have to say anything. Maybe just sit with the patient for a bit, look the patient in the eye, and think about what it'll be like to lose your hand as someone who needs it, like as for your bread and butter. Just sit for a bit, look at the patient and think about this. And that moment of connection, I don't know if it could build trust, but at that moment, if I'm a patient and I feel like this doctor cares, this doctor is trying to think about what I'm facing right now, maybe it's not a kind of deep trust, I trust you in my life kind of thing, but it's at least like, I think I can trust him enough to put my life in this person's hands. Yeah, at this difficult moment. I don't know if that makes sense to you, but this is what I feel, what I think as a scholar and as a patient. Yeah.
Thank you so much, Michelle.
Yeah.
Yeah, I think I really understood it better once again, the second time I'm hearing it. So yes, I think that was very helpful. I think one last question that you asked us to ask, so we will definitely ask it. So Winnie has asked, what is the difference between stories and narratives?
Okay. Stories are okay. Yeah, I asked you to ask this question right just now, right? No, but okay. So stories can teach us one lesson, two lesson quite didactically. You read it like once through and you're like, oh, okay. So the moral of the story is this. Yeah. When we think about narratives, narratives are very intricately crafted. They are really crafted by writers in order to provoke thought. There's a difference between the two. So there's a difference, as in sadly, like there is a big difference between like a very mediocre story and one that is like a classic, like everybody agree that it's canonical. Why? Because one takes craft and another doesn't, right? So the thing about narratives, if we want to answer it, if we want to think about it carefully, is that it allows us to read it in its different layers. So there is thought put into form and content. Now you're wondering then, oh, what about patient stories? Patients don't really have time to craft their stories, right? Like they're just telling you their stories on the fly. So why are they referred to as narratives? I think scholars came out of this concept of narrative to really point out that whenever something is uttered, whenever a story is being told, right, there is intention behind that story, and that intention needs to be excavated. Right, that intention needs to be excavated. If it's just referred to as story, people just think that you read it once and then you don't think much about it. But when we consider patient stories as patient narratives, then it tells us that there is a reason for us that we have to excavate it. We have to dig beneath the surface. So going back to that difficult patient example Joyce gave earlier, this generic difficult patient, when they go on and on about their lives and is not related directly to the situation at hand, then it's important to dig beneath the story and think about, why is this patient like oversharing in the first place? Is this something that I'm not listening? Like, is this like a call for help that I'm not attending to? So it really gives us pause when we think about patient stories, not as just stories, merely stories, but narratives that deserve our attentiveness. Yeah. Yes. Yes.
Okay, thank you, Michelle. I think we have to wrap up. So yes, I think I really learned so much. Once again, I want to say maybe we should I should listen to it for the third time. But I don't know whether Joanne has anything else to add.
No, thank you, Michelle. I like Joyce. I think every time I listen to you, I learn something new, and I think that is what what I enjoy lah. Yeah. So thank you so much for filling the gap. That I think that there's so many gaps within me that you have kind of like filled in a little bit over time, and I think hopefully I will continue to let it grow so that I can become a better physician lah. Yeah. Thank you.
I think sorry, maybe one last thing. This is what medical humanities does. It may sound very abstract, but once you get a hang of the language, because we're talking about two cultures, even though we're speaking one distinct language, it's actually two different languages from two distinct cultures. Is that as long as we keep our channels open to listen to one another, we'll get used to our languages, and then we can learn a lot more from one another. Yes.
Yeah. I think that's a nice reminder. So thanks very much, Michelle. Thanks also to Joyce and Joanne. That at the end of the day, yes, science and humanities actually they come from very different roots, so to speak, and they are different languages that we speak, even though it is supposedly in English. Yeah. And I think one way is to just keep the conversation going. So if this is the start of a conversation that's sometimes fraught with a bit of misunderstanding, so be it, and let's just keep at it. Yeah. So thank you very much, Michelle, for bringing the webinar to us.
Thanks for having
Thank you. Yeah, thank you. Thank you, Joanne and Joyce, for being our clinician discussants and also for fielding the questions. So we hope that, in time when we keep bringing together scholars and practitioners in healthcare, we can start more conversations about what matters to us as people in healthcare, whether we are the ones who are delivering healthcare, the ones training the people who are delivering healthcare, like the people in our office, or the ones who are receiving healthcare, like our patients. So thank you all. For our participants, thank you very much also for staying with us. And I hope you had a good time learning today. We'd very much like to hear your feedback. So tell me if you could just flash our feedback slide. Yeah, thank you. We want to hear your feedback, and don't forget also, for those of you who are keen on getting your CME points, do scan the first QR code. So that's the one in brown there. Fill up the feedback form and also get your name and details down so we can do your CME points for you. Okay. And we are definitely planning for more webinars in the next year. So if you'd like to be on our mailing list, do scan the second QR code. So that's the one on the right, the blue one. And we will put you on our mailing list and we will let you know once we have our schedule for next year. So thank you all very much. Thank you for spending your lunchtime with us, and we hope to see you at our next webinar next year. Yeah. Thank you all. Okay. So thanks, everybody. Yeah, thank you. Thanks, Joyce. Thanks, Michelle, and yeah, Joanne as well. Thanks very much.